Hello, my students. In the last chapter, you have studied cholinesterase agonists, including direct-acting drugs and indirect-acting drugs. From this chapter, you will learn cholinergic antagonist. Cholinergic antagonist is a general term for agents that bind to cholinergic receptors and antagonize the effects of acetylcholine and other cholinergic agonists. Based on the specificity of the drugs to the receptors, anticholinergic drugs can be divided into ion receptor blockers and receptor blockers. Here, right. Antagonists of some receptors also can be called by some receptors blockers. So anticholinergic drugs can be caused by cholinereceptor blockers. Atropine is the representative drug in this group. So also you will study anisodamine, scopolamine, and other synthetic agents. M receptor blockers, you will study tuberculin. It can block neuromuscular junction NM receptor. And NN receptor blockers, trimethoprim, block NN receptor in ganglia. So here, you mainly study M receptor blockers. Actually, in the world, many plants contain this substance, has some effects like atropine. So this substance in the plants can be caused by atropine-like alkaloids. The capital plants contain atropine-like alkaloids include belladonna, sun apple, poison tobacco, East poison tobaccos, devil's apple. There are many plants containing this substance. Now, here I want to tell you a story. Now, I think you know this. Okra, it is a dish made by okra. Do you like it? I like it. Actually, you can see this okra, the shape, it is look like devil's apples bars. About 3 years ago, an old man in Dalian city, one day he went out in the wild. He found a plant with the bars like okra. Wow, at that moment, he thought he was so lucky because this okra in the market, this vegetable is much expensive in North China. So he picked up many bars from the plants and took them home. Dinner, he and his family had eaten these bars. Actually, it was not okra. It was devil's apples bars. So I think you can guess the result. Finally, the old man and his families were poisoned. Luckily, he found in time. So they asked the ambulance and went to the hospital emergency room. They were saved in time. So actually, they was poisoned by these toxic plants. It was atropine-like alkaloid poisoning. So what are the symptoms? Can you guess? Actually, in the nature world, there are many plants contain these alkaloids, and most of them The flowers are very beautiful. Look at this, the Tura stramonium. Maybe many of you have seen these plants. Very beautiful. Yeah, they contain many alkaloids like atropine, scopolamine, yeah, and anisodamine. Many plants contain this, so they are toxic to our body. So don't try to eat them. Yeah. Okay, look at the drug. Muscarinic receptor blocking drugs. Just now I mentioned atropine. It is the representative drug in these families. Yeah. When you studied the cholinergic agonist, I also mentioned pilocarpine. It is representative drug of M receptor agonist. Muscarinic. It is the representative agents of reversible cholinesterase inhibitors. Yeah, so in the following chapters, you will study many drugs. And among them, the representative drug is the most important for you. You will spend much more time on these drugs, representative drug. Okay, atropine. It mainly blocks M receptor. For N receptor, its effect is really weak. So usually at the therapeutic dosage, that effect on the N receptor is ignored. So we usually consider the atropine as M receptor blockers. It is competitive antagonist for the M receptor because it can competitively block the actions of cholinomimetics at M receptor. It has very high specificity for M receptor, but atropine doesn't distinguish between the subgroups of M receptors. So for the subtype of M receptor, M1, M2, M3, yeah, atropine all can block. When atropine used in very high dose, it also can antagonize the N receptor in peripheral ganglia. An N receptor can be blocked by atropine, but usually in the clinical practice to treat some disease, we never use the atropine at so high dose. Pharmacological effects. Just now I mentioned atropine. It is a competitive antagonist for M receptor. So its effect, it is just the antagonism effect of acetylcholine. So that's the opposite to acetylcholine. Compared with the other organ tissues, the glands are relatively more sensitive to atropine. The secretion of the glands will be inhibited by atropine. The secretion will decrease. Especially salivary and sweating glands are more sensitive to atropine. When we use atropine at a relatively very low dose, just about 0.5 mg, the patients will feel dry mouth, acidosis, cutis, and dry skin. With the dose increase, lacrimal and bronchial glands secretion also can be decreased by atropine. When this atropine used in relatively large dose, even gastric secretion, it also decreases. But actually, this common therapeutic dose of atropine has very weak effect on gastric secretion. This is effect on glands. Our eyes have M receptor. You have studied pilocarpine. Pilocarpine is M receptor agonist, induces 3 responses of the eyes to pilocarpine, including miosis, decrease in intraocular pressure, and cyclospasm. Remember that? So, atropine, it is an receptor antagonist. So its effect on the eyes, the result is just opposite to pilocarpine. So it also includes 3 responses. Mydriasis, pupil size become larger, and increase intraocular pressure and cycloplasia. Because M receptor in the iris sphincter is blocked by atropine. So actually, iris has another piece of smooth muscle. It is iris dilator. Iris dilator, it mainly has alpha-1 receptor predominated by sympathetic nerve. So when M receptor in the iris sphincter is blocked by atropine, so sympathetic nerve innervation on the iris predominate, and then it will induce contraction of the iris dilator muscle. You understand? This is the result of atropine on the pupil size. So contraction of iris dilator, this is smooth muscle contraction, induce mydriasis. So at these conditions, the eye, it is unresponsiveness to light. It is unresponsive to light. When our eyes, our eyes always are responsive to light. It will induce meiosis by light. But at these conditions, this ability almost disappeared by atropine. So this is the mydriasis in the eyes. And with this mydriasis, this is mydriasis caused by atropine. And then this iris, this is smooth muscle, piled up at the anterior chamber. It here make this anterior chamber, this space is relatively narrow. So for the reflow of the aqueous humor through anterior chamber, even trabecular canal, trabecular work, here reflow to the blood vessels. This reflow way is almost blocked by the drug. So it will induce increased intraocular pressure. So here, I think you can understand, especially for the patients with glaucoma, atropine, it can increase intraocular pressure. It will weaken this disease. Do you understand? So usually we consider glaucoma, it is one contraindication for atropine. I think you know this word, contraindication. Yeah, in the following chapters, maybe we'll mention this word. It always means some disease. For a given drug, this disease, it is forbidden to use this drug, a given drug. Understand? So this disease can cause them by contraindications for a given drug. Understand? Opposite indications. It often means some disease. They are suitable to use atropine to treat, like that. So I hope you can understand the meaning. Here, remember, glaucoma, it is one contraindication for atropine. It means for the patients with glaucoma, try not to use atropine. Cycloplasia, it is caused by ciliary muscle contraction, ciliary muscle contraction caused by atropine blockade on the M receptor here. So, it often induces this suspensory ligament. It is relatively tight. So the lens become less convex. So the result of the vision, it is far vision. For the eyes, it loses ability to accommodate. So for near vision, it is blurring. This response is caused by cycloplasia because of the ciliary muscle is in paralysis, relaxed. Understand? Okay, that's all for this section. Atropine, it can block M receptor, but for the subtypes of M receptors, it has no selectivity. It is lack selectivity, and it also has less selectivity to the organ tissues. Almost the M receptor in the body everywhere can be blocked by atropine. So it has many pharmacological effects. Just now, I taught you effect on the glands, decrease the secretion of the glands, has effect on the eyes, induce mydriasis, increase intraocular pressure, and cycloplasia. So what are the other effects of atropine? And what of these can be treated with atropine? Let's go on. Atropine can block M receptor everywhere in the body. And many smooth muscles have M receptor, including GI tract, GU tract, and biliary tract and uterus. Now first, GI tract. In general, the walls of viscera are relaxed by atropine, particularly for those in spasm. Don't forget, atropine, I mentioned, it is one competitive antagonist of M receptor. So especially when the smooth muscle of GI tract in spasm, its antagonism, it is more obvious. So I think maybe someone has that experience. Maybe got some infection with bacteria in the gut, so feel abdominal part pain. That conditions, it usually caused by smooth muscle of the GI tract in spasm, so feel abdominal part pain. So it means the smooth muscle of the GI tract is overactivated by atropine, by acetylcholine. So under that conditions, if you use atropine, that symptoms of abdominal part pain, it will be corrected very soon. So when the wall of the viscera are relaxed by atropine, especially for those in spasm, this is the effect on GI tract. We also caused by this is antispasmodic effect. Genitourinary tracts. Smooth muscle of the ureter and the bladder wall is relaxed and voiding is slowed by atropine. So this effect, it also is useful in the treatment of spasm. If someone has inflammation in ureter and bladder, like cystitis, the common symptoms of these conditions is urgent urination, aldinuria, and frequent urination. So it also caused by irritation signs of bladder. So it often caused by smooth muscle of the bladder in spasm. So at these conditions, Atropine, because it is M receptor blockers, it is very useful to correct the symptoms of irritation signs of bladder. But at the same time, atropine also has a latency to cause urinary retention. So because of this result, atropine has another contraindication. It is prostatic hypoplasia. Remember, in the last section, I told you one contraindication of atropine is glaucoma because of increased intraocular pressure. But here, because of relaxation of the smooth muscle in bladder or ureter, it will make the urination more difficult, especially for those people with prostatic hypoplasia. I think you know this disease. For old men, it is relatively common disease because of degenerative development of prostate gland. Yeah, this disease is more occur in old men. Yeah. So especially for the old men, to use atropine or other M receptor blockers, it should be more attention. Yeah. Biliary tract and uterus, these also have M receptor, but usually act on the biliary tract. It is relatively mild than the GI tract and GU tract, and especially act on uterus. Atropine effect, it also is very weak compared with other smooth muscle. Okay, this is the effect of atropine on smooth muscle. Make this smooth muscle relaxed. But usually, the therapeutic dose of atropine on this smooth muscle, it can make this smooth muscle relax, but usually induce the secretion of gastric acid. That decretion is relatively weak. Act on the heart. Heart is innervated by parasympathetic nerve, vagus nerve, and together with sympathetic nerve. And if atropine can block M receptor in the heart, but the result it is more complicated depending on the dose. Now, first to read these two sentences. When atropine is used in lower dose, maybe 0.5 mg, it is induce initial bradycardia before the effects of peripheral block become manifest. Because at these conditions, it can block presynaptic M1 receptor that normally limit acetylcholine release in the sinus node and other tissues. With the dose increase in moderate to high dose, moderate dose, it often means the common used therapeutic dose. It can block vagal slowing and induce tachycardia. It may be because of blockade on M2 receptor on sinus node. So it also accelerates intravascular conduction. Can you understand? Okay, let me explain in detail with this figure. Now, for normal conditions, heart, here it means the effector cells of the heart. They have many M2 receptor. Once M2 receptor is activated by acetylcholine, the result is heart rate decrease. But this is a presynaptic membrane terminal. There are many vesicles, synaptic vesicles, contain many acetylcholine. And on the presynaptic synaptic membrane, presynaptic membrane, there are many M1 receptor. They can also be bound with acetylcholine, and the result, the function of this M1 receptor, it is negative feedback to regulate the acetylcholine release from nerve terminal. So once this M1 is activated by acetylcholine, release of acetylcholine, it will decrease. So the final result on the heart, it is opposite to this result. At these conditions, when acetylcholine release is relatively light, so heart rate may increase maybe. Understand? So once usually M1, now remember, M1 usually it is more sensitive than M2 to the agonist and the antagonist. Now look at it. When we use a low dose of atropine, because M1 is more sensitive than M2 to the atropine, so M1 is first blocked by atropine. The activation, the function of M1 is a negative feedback of release of acetylcholine. So once M1 is blocked by atropine, so the release of acetylcholine, this negative feedback regulation is weird. Understand? So acetylcholine release still increase. So there are more M2 receptor in the heart can be activated by acetylcholine. So heart rate, the result is decrease. So this is the bradycardia when used atropine at relatively low dose. It caused by activation or blockade of M1 receptor in presynaptic membrane by atropine. Could you understand? With the dose increase, moderate, even high dose of atropine, M1 and M2 all can be blocked by atropine. Understand? With the dose increase, M2 also can be blocked by atropine. Although M1 is blocked by atropine, this negative feedback regulation of neurotransmitter release, it also is abolished, disappear. So still secretion acetylcholine release of acetylcholine neurotransmitter also is too much. But here M2, many M2 are blocked by atropine. Acetylcholine lose opportunities to activate M2 receptor in the heart. So at these conditions, the result of the heart rate change, it is opposite to the vagal nerve's function. It is increase. So maybe induce tachycardia. Understand? Actually, the common used therapeutic effect of atropine on the heart usually is like this, because very few conditions we use atropine at this low dose. So there is a curve like this. With the dose increase, the heart rate changes. At the beginning, low dose of atropine induces bradycardia. With the dose increase, heart rate increase. Even the patients will feel palpitation. Understand? So I think here you also can understand atropine, with the dose increase, it can increase heart rate. So it also is very useful to correct bradycardia with relatively moderate, even relatively higher dose. Understand? Okay. Atropine also has effect on blood vessels and pressure, but usually at therapeutic dose, like it has effect on the smooth muscle, glands, and eyes. atropine has little effect on vessels and blood pressure. Only atropine used in higher doses. In some individuals at normal doses, therapeutic dose, atropine can induce cutaneous vasodilation. The response is erubescence, means skin flushes, especially in face and the neck. So actually, this response, it has a significance of improvement of macrocirculation. This cutaneous vasodilation, this mechanism till now it is not very clear. Because the blood vessels contraction or dilation mainly dominated by sympathetic nerve through alpha 1 and beta receptor. And the parasympathetic nerve have very weak on the blood vessels, although it can activate M3 induced vasodilation, but this is M receptor blockers. It also induces vasodilation, especially cutaneous vasodilation. So because this mechanism is not very clear, it just guys. Maybe atropine can inhibit the secretion of sweating glands, so sweat secretion is decreased. This sweating is one way for our body to release heat, heat releasing. So maybe body temperature can be increased because of inhibition of sweating glands. So this is compensatory response of the body, cutaneous vasodilation. So it can increase the heat release. Understand? And some people considered it is direct effect of atropine on the blood vessels. Yeah, just guys, not very clear. But actually, this vasodilation sometimes it is used to improve macrocirculation. Yeah. Atropine, it also can act on the seeing eyes. And usually in the eurodose, it has minimal stimulant effects. At that conditions, the people just feel actually excitement. With the dose increase, like 10 mg, it is a toxic dose of atropine. And usually, any individual will show some symptoms like excitement, agitation, hallucinations. Understand? These are the common symptoms of stimulant effects on seeing eyes. But with the dose further increase, or because of overexcited response of seeing eyes, finally it will convert into depression. So the patients will exhibit coma, even respiratory paralysis. Yeah, these are the pharmacological effects of atropine. Try to think of where M receptor distribute and what are the functions. So the effect of atropine on the M receptors is just the opposite to acetylcholine. This is a summary about the pharmacological effect of atropine. Inhibits the gland secretion, has a 3 response of the eyes, major eyes, increase the intraocular pressure and cyclopedia, and relax the visceral smooth muscle, relieve the inhibition of the vagal nerve, and dilate the blood vessels, and improve the macrocirculation. Usually, it has a stimulant effect on the seeing eyes. Of course, very large dose, it also induces depression. Okay, actually, that's all for this section. And you know, M receptor has no selectivity to the subtype of the receptors, but actually different receptors or in different organs, they also have different extent sensitivity to the atropine, So usually the heart, at low dose induce bradycardia, and the glands are more sensitive to atropine. Secretion decreased. And with the dose increase, even, further inhibition on the gland secretion, it also induces a dilation of the pupil, blurring of near vision, and also increased heart rate and marked dryness of the mouth and smooth muscle relaxed. Further increase at toxic dosage. It often induces stimulant effect on the seeing eyes, hallucinations, and delirium, even coma. Those dependent effects of atrophy. Okay, that's all for this section. So here, maybe now you can guess what are the symptoms of deuterostromonium in that old man who was poisoned by false ochre. It is this lungs poisoned. So can you guess what are the symptoms? And what disease can be treated with atropine? Atropine has so many pharmacological effects. They also has many curative effects. Some are useful in the treatment of disease. So what disease can be treated by atropine? So go to study next section. You will get the answer.